السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم ومساءكم وين ما كنتم. First of all, I just want to make sure my voice is clear. Can someone write for me, please, if you can hear me clearly or not? Okay, perfect. Thank you. So before I start today, I would like to thank Dentoscope and especially Dr. Hay for the kind invitation. It's an honor for me to be here. Today I will talk about the management of different situations of immediate implants. And the other thing before I start, regarding the questions that have been submitted through the Google document, I will answer all of them at the end of my presentation. So now I will flip my cam and I will try to stabilize my phone. Hopefully it's going to be clear for you. Just give me a second, please. So I will try to make sure you can see the whole screen clearly. Oops. Okay, let me increase the brightness a little bit. Okay, perfect. So, as I said, today we're going to talk about the management of immediate implant. And before we start talking about the cases and discussing the different scenarios, we should know what does it mean immediate implants. So, the literature showed multiple definitions and terminology were used for the timing of the implant placement. However, Boozer Group standardized this terminology so we can use them easily in our studies. So he classified them into four main categories. The first one, which is the immediate implant, and that's mean after extracting the tooth you will place the implant on the same time. The second and the third category, which is the early implant placement, that's mean after extracting the tooth you will wait between 4 to 8 for the soft tissue healing or 3 to 4 months for the partial bone healing before placing your implant. And finally, the healed site, where he called it the late implant placement. So after extraction the tooth you will wait for more than 6 months, then you will place your implant. So for today's presentation, we will focus mainly on the first category and we will discuss multiple scenarios regarding this topic. But before we discuss the cases, let's review the literature and talk briefly about the history of the immediate implant. So more than 30 years ago, Lazara reported placing implant in the fresh extracted socket will minimize the overall time of the treatment, because he explained that it will combine both the post-extraction healing period with the integration phase of the implant. That means the patient will wait shorter to have a restoration later on. So the technique was utilized at that time is to place a long implant exactly in the middle of the socket, as you can see here. And after that he will cover the implant with non-resorbable membrane, and in that case he used Gore-Tex membrane with no intention of primary closure. And he explained that the remodeling will happen on the both buccal and lingual aspect, or buccal and lingual outer aspect of the socket, and bone fill will be formed inside. However, it was unpredictable at that time. So Arojo and co-workers found in early study that after tooth extraction, dimensional changes will happen during the healing period. So here you can see both the buccal and lingual plates are at the same level after 1 week of the extraction. However, after 8 weeks you can see severe resorption in the coronal third of the buccal plate. So after this study, they thought if they can place an immediate implant of the socket, it will prevent the remodeling. However, it showed similar result to the previous study, that the immediate implant did not stop or did not prevent the remodeling on the buccal plate. So later on, they modified the technique, and what they found in this study, that the presence of large gap between the implant and the buccal plate, and when the gap is filled with a bio-os collagen, which is a xenograft material, it will promote a new bone formation and enhance the level of the bone to implant contact. So during the cases, I will explain more about the gap. So at the beginning they call it the buccal gap, then they I would say change the terminology to jumping gap. So let's start with the management of single implants in the aesthetic zone. So this report by Worley in 1998 is considered one of the first studies published in immediate implant and immediate provisionalization in the aesthetic zone. And the objective of this principle is basically to predictably maintain both hard and soft tissue architecture and achieve aesthetic restoration in the premaxillary region. So after this publication, unlimited studies have been conducted to understand this area more and more. So recently, the ITI came with this recommendation for immediate implant placement, and they mentioned these 6 categories. First, you need to have an intact thick facial bone of at least 1 millimeter and thick gingival phenotype. Second, no active infection or no acute infection should be in the area, and you have enough palatal bone to stabilize your implant, and the implant should be placed in a flaplets approach. And regarding the implant position, they mentioned that apicocoronally, the implant is supposed to be 0.5 to 1 millimeter apical to the buccal crest, and the reason behind that, just to compensate for the buccal plate remodeling and also to provide a better emergence profile for the final restoration. And finally, you need to maintain a gap at least 2 millimeters between the implant and the facial bone, and this gap is preferable to be filled with a xenograft material. So let's start with the first case. So this case was done by my colleague, Dr. Amr Al-Kandari. So regarding this patient, he came to our clinic to extract tooth number 8, which is number 11, the upper right central incisor. And as we can see, it has an extensive dental caries. However, from the clinical examination, we can notice that the gingival margin on the tooth that need to be extracted is more coronal compared to the contralateral tooth. So in this case, the soft tissue in our favor. So as a protocol for immediate implant placement, CBCT need to be taken before placing any dental implant. Why? To have better idea about the case and also to optimize your treatment outcome. So in this case, as you can see here on the left picture, we have sufficient bone thickness to place the implant more palatally. So the extraction was done as minimally traumatic as possible using the periotome. So the periotome, it's a small instrument that it will goes in the interproximal area and sever the periodontal ligament. So please don't try to luxate the tooth with the periotome, otherwise there is high chance you will fracture the instrument inside the socket, or sorry, inside the periodontal ligament space. So here, after the extraction, we measure the distance between the buccal plate and the gingival margin, because again we are going to place the immediate implant in a flapless approach, so we cannot know, or we don't know exactly where is the buccal plate, so we can submerge it 1 millimeter apical to it. So that's why we need to do this measurement, because we will use the gingival margin as a guide to us to place the immediate implant. So for example, if we are placing a 10 millimeter here, you will drill based on the gingival margin 15 millimeters. So the implant will be 1 millimeter apical to the buccal crest. So the implant, as you can see here, placed more palatally to be restored with a screw return crown and the buccal gap filled with the xenograft material. So in the aesthetic zone, provisional restoration is preferable to optimize the clinical outcome. And as Stephen Cho said in his publication, it acts as a prosthetic socket seal to protect, contain, and also to maintain the blood clot and the bone graft. So here, immediately after the implant placement, and due to the low primary stability, we fabricate a custom healing abutment to preserve both the interdental papillae and the gingival margin. So this is the 3 months follow-up. You can appreciate both the marginal gingiva and interdental papillae are maintained. So this is the first case in the aesthetic zone. It's a straightforward case. Everything is favorable, and as you can see, everything was maintained easily. So let's move now to another case, which was done also by my colleague Dr. Amar. So this patient showed up to extract non-restorable tooth number 10. And again, from the clinical perspective, the gingival margin in our favor. So basically you can see this is the normal gingival margin of the lateral, which is about 1 millimeter coronal to the center and the canine. However, the contralateral tooth has a recession. But in this case, the patient is happy with the restoration here and he doesn't want to change anything. And second, if you attempt to do a root coverage on that tooth, you may not get a complete root coverage. And the reason behind that, you can see we have a slight interproximal attachment loss. So we know from the classification of Miller and Cairo, if you have an interproximal attachment loss, you cannot achieve complete root coverage. So in this case, our aim to place the immediate implant and try to mimic the contralateral tooth. So however, we took the CBCT and we saw many differences in this one. So first, we have limited bucco-palatal thickness of the bone, which is around 6 to 7 millimeter. So from this picture, we planned our implant to be exactly in the middle of the tooth. So we're gonna use a narrow immediate implant so we can provide a buccal gap that will be filled later with xenograft material. But the second thing we notice here, we have a periapical lesion. So the question is, does this periapical lesion will prevent us from placing the immediate implant or not? So first, let's talk about the thickness of the facial bone on the anterior maxilla. The majority of the anterior maxillary teeth have less than 1 millimeter facial bone or buccal plates. That means if we go with the recommendation of the ITI, also, although it's really good, however, we cannot find this ideal situation every time. So we need to be more flexible. We need to know what's the biology and how to deal with every case uniquely. The other thing regarding the infection in the extracted socket or the endodontic infection or the periapical pathosis, many case series systematic review of RCTs found comparable results in the survival rate of implant placed in intact socket or implant placed in infected socket. So we have good body of literature to support our treatment. So here we remove the crown first, and again, similar to the previous case, we use the periotome to sever the periodontal ligament, and after that we use small laxators and the forceps to extract the tooth. And as you can see in this picture, we have the periapical pathosis, or the granulation tissue, is attached to the tip of the root. So in the literature, different degranulation protocols were published. In this case, or in our clinic, we usually use just regular saline and thorough curettage just to make sure there is no granulation tissue or no soft tissue remaining inside. So we do not use any chemical or antibiotic in these cases. So the implant was placed with the same protocol and similar to our plan, and the buccal gap was filled again with the xenograft material. So in this case, actually we had a good primary stability. However, because we were conducting a couple of cases or couple of case series, that's why we decided to use a custom healing abutment to see how predictable this technique. And here you can notice in the 3 months follow-up, both the soft tissue thickness and the intergingival papillae are maintained. So in these cases, the aim of our treatment is to maintain what we have, but sometimes we cannot do that. Why? Because we will see, or we will start with a more compromised situation. So let's see this case. So from the clinical perspective, we can see this case is kind of unfavorable because we have slightly more recession on the tooth that need to be extracted. So here, tooth number 8, which is tooth number 11, the upper right central incisor, is deemed non-restorable from the referring restorative dentist due to a fracture, and now the crown is cemented with a temporary metal post, and you can see it here in the radiograph. So again, we take the CBCT and we can notice we have thin buccal plate. It's around 0.75 millimeter, and we have enough coronoapically length of the bone, which is around 15 millimeter, and we have 7 millimeter in width buccopalatally. So in this case, we can easily place the implant and engage it on the buccal plate. So similar to the previous case, the crown was removed first and the extraction was done as minimally traumatic as possible using the periotome and the forceps, as you can see here. After that, degranulation completed and the socket inspected. So every time after the extraction, we inspect the socket to make sure there is no dehiscence or fenestration present. So moving forward, here you can see my osteotomy. My aim to place the implant 4 millimeter from the gingival margin, because again, I measured this distance, and most of the time, if you have an intact periodontium, the distance between the gingival margin toward the bone is around 3 millimeter, and we place our implant 1 millimeter apical to the buccal plate. And here you can see from the occlusal aspect, the osteotomy was made more palatally to achieve the 2 millimeter buccal gap and to restore the case later with a screw retained crown. However, after the implant placement, we got kind of low primary stability. In this case, it was around 20 to 25 Newton centimeter. So we decided to not do a provisional restoration and just to do a custom healing abutment, because we know that it will work perfectly. And the other thing, usually after stabilizing the temporary abutment, we need to place a rubber dam all the way apical to protect our surgical site. So we don't want any material either flowable or packable composite to leak inside our surgical site. Please just make sure every time you are doing a provisional or you are doing a custom healing abutment to protect your surgical area with a rubber dam. So as I mentioned at the beginning, due to uneven gingival margin, as you can see here, subepithelial connective tissue graft was planned to augment both the height and the thickness around the implant. Thereby, we're going to enhance the aesthetic outcome. So tunnel was made first here using the microblade, and after that blunt dissection was made till the level of the mucogingival junction. After that, sharp dissection was made in the mucosa, so we can dissect all the fibers there utilizing modified urban knife. So this knife, it's one instrument in a kit of the tunnel that we use usually for root coverage procedures. So after that, the subepithelial connective tissue graft was harvested from the pellet, and in this case I used the single incision technique that described by Hüsler in 1999. And you can see here in this picture 1 millimeter of the connective tissue left at the margin. So here this is my incision, will go all the way around, and I will harvest my connective tissue graft from this line. So after I suture my flap here, it will lay over this connective tissue graft, because they show it may minimize the chance of sloughing of your flap. So after that, the buccal gap was filled with the xenograft material, and the connective tissue graft was stabilized by 2 suspensory sutures, as you can see here. And immediately after the procedure, you can see the gingival margin is kind of more coronal compared to the contralateral tooth. So I didn't mention that at the beginning, all these cases, they left our clinic with an Essex retainer. So every time we are dealing with the immediate implant in the aesthetic zone, the patient need to go out with either a provisional restoration or at least a removable or an Essex retainer. So for this case, this is the 12 months follow-up after the final crown placement, and you can notice the papillae was preserved and the gingival margin is slightly more coronal compared to the contralateral tooth, or compared to the initial I would say picture of that tooth. So this is the end of the first, I would say, situation on the aesthetic zone. So now I will just check the chat to make sure no questions has been written or sent. So please give me a second to check the chat. So there's a question here by Saad. When you say infected socket, is it suitable for implant? Can you be specific about that? Okay, so for the infected socket, okay, it's a really good point. What I meant, for example, if you have a periapical bathosis and it's an acute or active, that's mean there is suppurations coming out, there is pain on percussion. In these cases, I would rather to extract the tooth, clean the area, do a ridge preservation, and come back. However, sometimes we have a chronic periapical or chronic infection or chronic periapical bathosis. In these cases, I would say you can place your immediate implant there. Okay, I think there's another question here from Dr. Haif. Okay, no, it's not a question. Okay. I believe no more questions so far, so let's move forward. So now we preserve the interdental papillae, we preserve the gingival margin level. However, how can we transfer this picture to our restorative dentist so he can mimic exactly what we made for him? So that's why something really important for me as a periodontist or as a surgeon to provide the restorative dentist with a custom impression copying. And there's different techniques how to do the custom impression copying. The way I do it, first I stabilize the implant analog in the stone. After that, I attach the provisional restoration or the custom healing abutment to the analog, and I inject a blue mousse material, which is the bite registration material, to capture only the emergence profile of the provisional crown, as you can see here. After that, the impression copying will be stabilized, and any, I would say, resin material, JC resin or flowable composite. So in this case I use JC resin material to capture the emergence profile that I need, and finally I polish and glaze the custom impression copying to make sure it will not irritate the soft tissue there. So every time you are dealing with, even if you are dealing with delayed situation, when you place an implant in the aesthetic zone and you did the provisional restoration, later on if you like how the tissue looks like, you can do this technique and provide your restoring dentist or the prosthodontist the custom impression copying so he can mimic exactly what did you do. So now there is a really good question. Is it always aesthetic when we talk about the anterior maxilla? Let's see this case for example. So this patient is 92-year-old and she was referred to me to extract the remaining roots of the upper canines and the upper left lateral. And based on the referral, they told me to evaluate the situation if the patient can receive an immediate implant. So again, if we notice in this case, first, the teeth are kind of equigingivally. That means there is no interdental papillae to preserve them. Second, she missed these teeth for a long time. So in this case, there is nothing to preserve, because maybe the gingival margin, yes, but in this case it's not that critical, because again, the final treatment plan will be a 6-unit bridge supported by 3 implants. So again, as with any different case, I will take a CBCT and to evaluate the sites. And fortunately, although the patient is really old, you can see here on the canines we have really good bone. So I can easily place my immediate implant and engage the palatal aspect or the palatal bone. However, in the upper left lateral, the bone was really thin. So I decided to place the implant on the central incisor first to have better distribution of the implant, and second, because we have also better bone on that side. So again, like the previous cases, extraction was done as minimally traumatic as possible, and you can see everything is intact. There is no tearing in the flap or no tearing in the interdental papillae, and the implant was placed more palatally to provide a really huge buccal gap. And in this case we are expecting a really big gap, because for the canine it's really a huge root, especially on the buccopalatal dimension. And here, after the implant placement and the site is grafted, and finally, because again there is nothing to preserve, and usually if I have nothing to preserve, I take a piece of the free gingival graft and do the socket seal technique to close the socket with the free gingival graft. However, given the fact that this patient is really old and I don't want to do any surgery on the other side, I decided just to place a collar tape and stabilize it with sutures. And here you can see the other side. Again, the same technique was used. Minimally traumatic extraction first. After that, I just raise a small flap here, so I will place the implant based on my plan next to the extraction socket, and I will do just simple ridge preservation in that area, and I will close everything, or I will cover everything with a collar tape. So here you can see the implant from the occlusal aspect. They are well distributed. And here after 4 months you can see the healing is uneventful, and I just used the guide, which is only an Essex, to punch the immediate implants. And for the anterior implant I just did a small incision, as you can see here, to replace the cover screw by healing abutment. And the patient left like this, no sutures were replaced on this case. So now we finished talking about the implant in the aesthetic zone. So let's go and talk about the posterior area. Is it always feasible to place immediate implant there or not? So let's start with this case. This patient was referred to extract the upper second premolars due to caries underneath the crowns. So the restorative dentist deemed them non-restorable, and now the patient came to me to extract both of them and see if immediate implant placement can be placed. So I took a CBCT and I found the patient has extremely long palatal root, which is around 15 millimeter, as you can see here. So my question is, can we place an immediate implant? The answer is definitely yes. The other question, should we do it? For me, I would say no. And the reason behind that, okay, so we have, for example, here 15 millimeter root, and I need at least 3 to 4 millimeter to engage my implant, so I can end up with a good stability. So definitely I will use between 14 to 16 millimeter implant. So why I don't like this implant? Because I saw during my residency, sometimes patient came to us and he has a really long implant, and when you try to retrieve them, because it has, for example, peri-implantitis or severe bone loss, so even if the implant lost almost 50% of the bone around it, there is 50% is still engaged. And that means in case you will remove them, you may cause a huge damage to the site to take the implant out, and you will start building the bone from the beginning. So that's why sometimes I think it's wise to just take the tooth out, do a ridge preservation, and come back and place your implant. And that's exactly what I did in this case. You can see extraction was done as minimally traumatic as possible. I just grafted the site with a FDBA because all the walls were intact, and it's covered by collar tape or collar plug, and just simple intractable suture, as you can see here. And in 3 months, as you can see, the site healed nicely, and I have this huge bone. So now I can easily place a normal implant length between 10 to 12 millimeter. So for me, this is one rationale why I don't like to place really long implants. So in this case, this is 3 months after placing the implant. So the patient came to me just to evaluate the implant before I sent him back to the restorative dentist so he can start the restorative procedure. He came and he fractured the distal molar, as you can see here. And so I told him, okay, for me it looks non-restorable, but we need to take another consultation from your restorative dentist just to make sure he agreed with that. So I sent the patient back to the restorative dentist, and he agreed with me that this tooth needs to be extracted. So in this case I was lucky because I already have a CBCT from a previous from the previous case, which is placing the implant for the premolar. And I can see here from the CBCT the patient has really wide interradicular bone, so you can easily place your implant in this area, as you can see. However, if you can see the measurement from the bone toward the sinus is between 8 to 9 millimeter. So in this case, I decided to do both immediate implant placement and vertical sinus elevation. And one of the easiest way to do it from my perspective is to use the osteodensification burrs, because you can elevate the sinus and also enhance your primary stability. So in this case, I use the tooth as a guide, as you can see here. So I drill through the tooth to make sure I am exactly in the middle. And after that, I did the extraction and just verify the position of the implant. I placed the implant exactly where I want it, and in this case, I did something different. I grafted the site with FTBA, not with xenograft. And my rationale in this case, because first I have really wide or really big jumping gap in every direction. So on the anterior area, usually we stabilize the implant on the palatal bone, so the implant will be stabilized on a native bone. However, in these cases, if you are trying to stabilize the implant on the interseptal bone, you will feel it really much. So I'm expecting a resorption later on. So if I fill it with the xenograft, to be honest with you, I don't like my implant to be surrounded by xenograft all around. That's why I would prefer to use an FDBA, so I can end up with a really good amount of vital bone later on. And in this case, again, I did not use any sutures, although it's not in the aesthetic area. I just fabricate a custom healing abutment to protect my site, and also no collar tape was placed over the bone, just the custom healing abutment, as you can see here. So I remember this case was one of my last cases I did before the COVID closure. So however, after that I graduated from my residency and I couldn't follow up with this patient later on. So here you can see the picture from the buccal aspect. Usually, if I don't have a guide, I use the adjacent teeth and the opposing as a guide. So as adjacent, I was trying to follow the direction of the implant mesodistally, and for the opposing, I usually aimed for the screw retained restoration. So in this case, my aim to occlude over the inner inclination of the buccal cusp, because this is where will be exactly in the middle or the future central fossa of this crown. So now we finished discussing the maxillary teeth, both anteriorly and posteriorly. Let's talk about the mandibular area. But before we go to that, let's check again the chat just to make sure there is no questions. Okay, great. I believe there's no questions so far. So let's move on, but let me just stabilize my cell phone better. So let's start moving. Okay, I believe now it's good. So let's move forward with the situation in the mandibular teeth. So here's a case. The patient came to me with an unrestorable canine, as you can see here. And again, for me, I would say not all the time, but most of the time, when the patient came with an unrestorable tooth, and from the clinical examination, I think he has a good bone, immediately I will take a CBCT to make sure. If there is enough bone, I will do my immediate implant. Otherwise, I may delay it. Because some situation you will see you have really thin bone, so you have only a shell behind the roots. In these cases, I will not risk my implant. I will just do a ridge preservation. After that, I will open it and, for example, place the implant with simultaneous GBR. So let's go back and to see this case. So this is a badly broken canine, and as you can see here, there is a periapical lesion. However, there's no abscess coming from the tooth. There is no pain in percussion and palpation. So I treated this case similar to the case I did on the upper maxilla. First, I opened a flap because it was so hard to extract the tooth, and second, because it's a lower mandible and sometimes it's more forgiving for us to open a flap there. However, sometimes even in the anterior area, if you need to open a flap, you're supposed to open a flap rather than just try to push against the interproximal papillae and jeopardize them. So in this case, I open a flap, and I saw also, if you go back, you can see there's a small periapical ptosis here. So after opening a flap, I just irrigate with saline. I curate everything and degranulate everything just to make sure there is no more granulation tissue inside the socket, and I place the implant in a favorable situation. As you can see here, it's more lingual, and I provide a really good buccal gap that was filled later with a xenograft material. And finally, I just did small releasing incisions inside and achieve kind of primary closure, because we cannot say primary closure unless you remove the sulfur epithelium from the socket. So here you can see the 2 weeks. It looks really great. There's a small opening, but you can see the immature connective tissue or the immature soft tissue is building up here. And here the case at 4 months. So in this case, I did small incision to do the second stage, and as you can see, the bone grows over the implant. So I would say most of the time when you place the implant and you submerge them between 0.5 to 1 millimeter, you will see this situation where the bone will grow over the cover screw. So I just remove the bone gently with the back action chisel and replace the cover screw with a healing abutment. And now the patient can be sent later to the restorative dentist to start the prosthetic process. However, usually if it's not in the aesthetic area, I don't do the provisional restoration. I just place the healing abutment for them, then I send them back. So now we're going to talk about different situation, and this time we will talk about the second premolar. So this patient came to me again with an unrestorable tooth, which is the lower left premolar. So again, I took a CBCT, but in the lower area, especially in the second premolar area, it's very critical because most of the time the nerve will be exactly in the middle of the ridge, as you can see here. And in this case, I have almost 3.5 millimeter away from the nerve. So usually for the upper immediate implant, we try to stabilize the implant where exactly? In the apical part, correct? So we need to engage at least 2 to 3 millimeter apical to the socket so the implant will be stable. However, in this case, if we do that, we will hit the nerve. And we know from the Dr. Mesh study, the zone of safety, you need at least 2 millimeter away from the nerve. Otherwise, there is high chance that you may, I would say, you may disrupt, the nerve and make a complication later on. For example, paresthesia and other things. And something really important, I should notify you that most of the implant drill are 1 millimeter longer than your implant. So when you drill 40 millimeter, it's actually drilled for 11, sometimes 11.5. So just keep it in your mind that the implant drills are longer than the implant, I would say, in most of the systems. So in this case, I decided to place an immediate implant. However, I will utilize the mesial and the distal wall to stabilize my implant. Is it risky? Yes, it is. However, with the proper planning, of course, you can do it. So the mesodistal, you can see here, it's around 3 mm, 3.9 in different sections. So in this case, I plan to use a platform switch implant with 5 mm diameter, and the platform will be around 4 mm. So here you can see the clinical picture. This is the non-resorbable tooth. The extraction was performed again as minimally traumatic as possible, using the same technique exactly, periotome, then small laxators. And the implant was placed exactly in the middle, and you can see the gap here from both the buccal and lingual aspect of the implant. And the gap was filled with xenograft material, and finally I placed a healing abutment and covered the xenograft material or the bioos with a collet tape. And here you can see the 4 months healing. Everything looks perfect, and now the patient is ready to have the final crown. So let's move now to a final case, because I would say now it's around 1 hour of discussion and speaking, and I'm pretty sure everyone is tired or got bored. So let's discuss this final case. After that, we will jump to answer your questions. So this patient was referred to do crown lengthening for tooth number 31, as you can see here, which is the lower right second molar, the 4-7. And so after the clinical and radiographic examination, I informed the restorative dentist that it's so hard to perform a crown lengthening in this tooth, and for a couple of reasons. First, you can see the molar has really short root. Second, there is no interocclusal space, which is going to require a huge removal of the bone and also huge plasty of the adjacent to perform crown lengthening. So I told him, and the third thing, which is the forcation, is really close. So if I will do the crown lengthening, there is high chance I will expose the buccal forcation. So I told him maybe it's advisable to just do an extraction and place an implant there. So for this case, it was back and forth multiple times, and the patient is young and he got bored because he did the endo treatment, then he redone the endo, and based on the endo they said this is only a scar tissue after the first endo treatment. So he got kind of frustrated because he did everything to save that tooth. By the end, we told him, sorry, this tooth needs to be extracted. So he told me, listen, please do whatever you can to take the tooth out and place immediate implant. So based on the interocclusal space, as you can see here, it will be tricky. However, I took a CBCT and said, okay, I will evaluate your CBCT and see if I can place the immediate implant or not. But before that, generally speaking, if we are planning to place an immediate implant in the lower molar teeth, usually we stabilize the implant where exactly? In the interradicular bone. As you can see here, we follow this line and place the implant. However, in this case, if we do it, we will end up with the implant more distal, and the tip of the implant will be mesially. So I don't think we should follow this rule every time, because again, each case is unique. So in this case, my aim is to parallel my implant with the adjacent molar. So I decided to place it against the interradicular. So I will place the implant on the interradicular bone again, in the mesial socket against the interradicular bone, as you can see here. So I took a CBCT, and in this case I was lucky because I have a huge distance from the nerve, and second, the nerve is, as you can see here, because we know the route of the nerve, it will go more toward the lingual blade every time we go posteriorly. So in this case it's kind of against the the lingual blade, so I can easily place my implant here. Also, I can go maybe at the same level of the nerve without damaging it. So I planned the case for immediate implant. So I did the extraction, as you can see here. I placed the implant on the mesial socket against the intraradicular bone. And the second thing I did not mention is, sorry, because they don't have enough intraradicular space, and they are planning to do crown lengthening on the upper molars because it has an extensive dental caries. They asked me to submerge the implant around 3 millimeter, so they can end up with at least 6 millimeter interocclusal distance by the end. So this is exactly what I did in this case. I submerged the implant 3 millimeter. I grafted the side. However, maybe in this case I was unlucky because I couldn't find my long healing abutment, so I used just a short healing abutment, and to be honest with you, in 2 weeks the implant was completely covered over the healing abutment. So after that I transferred the case to one of my colleagues, and he did the second stage over the healing abutment, and he replaced the short healing abutment with a 6 millimeter long healing abutment, as you can see here in this picture. And after that he performed the crown lengthening, and as you can see here, there is enough space, and they said also they will remove more from this crown later on. And from the x-ray you can see here, this is the implant placement, and this is the bone level at the beginning. In this case we need to remove a little bit of the bone, otherwise we will end up with a bad situation where we have a really deep pocket in this area. So we did kind of osseous surgery around the implant just to make sure the implant will be in a favorable situation. So now the case will be ready to be restored later on. So at the end of this presentation, I would like to thank all of you to being here today. Again, for me it's an honor and pleasure to be with you and explaining my cases and sharing all of them. And please feel free, if you have any questions or concern, just write it down in the chat. And now I will just take my phone from the stand, and I will go to your questions that you submitted earlier and answer them. So let's go with the first question. Here it's saying, what's the impact of implant design in immediate implant placement? I would say, generally speaking, try to use tapered implant, not straight implant, because you will end up with better primary stability, and also sometimes you will avoid, for example, if you have an apical concavity and you have a narrow diameter in the apical part of the implant, you will avoid penetrating or perforating that buccal plate. And second, some companies, they provide an aggressive threads, so they are really good in the placement of the immediate implant, because again you will end up with a nice stability on these implants. So the second question is saying, in the hospital I am working there is no surgical guide. What are the surgical tips that can help me to place an implant in the correct position? I believe I answered this question during the presentation. So basically, if you are placing an implant between two teeth, usually you will try to follow them, and sometimes if they are in two different angles, you will follow the anterior implant. And regarding the buccolingual or buccopalatal position, usually I use the opposing tooth as a guide for me, because we know from the anatomy where this tooth will occlude later on, so we can follow it. So I hope I answer your question clearly. So going to the third question, if there any radiolucency, even if it's small, the immediate is not an option. I believe I show you a couple of cases today where there was a periapical lesion, and there's different studies supported that, but just make sure there is no acute infection in the site, there is no separation or pain on that area. So the fourth question, do you prefer if we have adjacent tooth to do immediate or we socket preservation, and why? Actually, it doesn't matter if you have an adjacent tooth or not, because sometimes, especially for the full mouth cases, some situation we do full mouth extraction, immediate implants everywhere, so there will be no adjacent tooth. So I would say it depends on the situation, it depends on the proper planning. The adjacent tooth, it may help you with the angulation, however, it's not mandatory to be there. So the next question, do you recommend always doing it one stage or two stage? Also regarding bone augmentation around it. Actually, I did not understand this question clearly, but for the first part of the question, most of the time, if it's in the anterior area, I will do it in one stage, and either I will do a custom healing abutment as you saw, or I will do a provisional restoration. For the non-prosthetic or non-aesthetic area, sometimes I bury them, especially if I have low primary stability. So here, what's the preferred bone augmentation materials during immediate implant placement, the FDBA or FDBA or BIOS? Most of the time, if it's an anterior implant, I will use BIOS, which is the xenograft material. And the reason behind that, because first, there's so many studies show that this material has a very low turnover rate, or very low or very slow resorption. And second, it can maintain the space for a long time. However, in a couple of situations, when you have a really big, I would say, jumping gap around the tooth, and you see you don't have enough native bone to stabilize your implant, in this situation, I would rather to use FDBA, because we know from different studies that you will have more vital bone around the implant when you use FDBA or allograft material in general. Okay, so regarding the American board, difference between the American Saudi board. Okay, so to be honest with you, I don't know exactly the Saudi board, but I believe when we say Saudi board, that means the residency and the board examination at the same time. So for the Saudi board, they are trained and examined on the same time. For the American board, it's different because your training is separate from the American board. So after your training for 3 years for example, in periodontics, you will become a periodontist. So you don't have to take the board to be a periodontist in the States. However, by taking the board, you will challenge the board examiner, and it's more prestigious. And even when you come back, for example, to the country, they need a board from you so they can classify you. And the last question here, in immediate implant, do we do immediate loading? I believe when you say immediate loading, that's mean in the full mouth cases, most of the time, yes, we do that. However, in single implant situation, it depends on the stability. So if you have a good stability, I will do full provisional, but again, it will be out of occlusion. So you need to check the centric and eccentric contact just to make sure there is no contact at all, because otherwise there is high chance you will harm this implant and it will fail really soon. Okay, so I believe I answered all these questions. Now I will go back to the chat and see Hello, Dr. Muhammad. It's an honor that you're attending my presentation today. So regarding your question, what's the deepest you will submerge the implant? I would say, generally speaking, between 0.5 to 1 millimeter. But in some situations, especially on the last case you saw, I submerged around 3 millimeter. But later on, I removed or I did osteotomy around that implant and distal to the molar, just to make sure I have a harmonious architecture there. There's a question from Saad. Can you talk about the cost and range? To be honest with you, I don't know exactly the cost in Saudi Arabia. However, here in the States, it differs from private practice to private practice and from private practice to a dental school. So in the dental school, generally speaking, it's around $1,000 only the implant, and the restoration, which is the crown and the abutment, it will cost between $1,200 to $1,400. So I would say total of maybe $2,500 to replace single implant. So does the phenotype has an impact on how deep you submerge? Actually, Muhammad, I know maybe you're referring to the zero bone loss concept. I don't believe a lot on that situation, because some studies show that even if you place, for example, a long healing abutment and you obtain a primary closure, you will not increase the thickness. So for me, I am an open-minded person. I will try to do it, but sometimes it doesn't work, to be honest with you. So sometimes if you just add a graft there, you will end up with more thickness. So regarding how deep, again, I will go mainly 1 to 1.5, because the way I trained here from my first school or from the second school, we use the predetermined margin to place the implant. So we should know where is the margin will be, and from there we measure around 4 to 5 millimeter and place our implant. Okay, Muhammad, I'm so sorry. Dr. Khalid Hamdan, you are my teacher, and thank you very much. It means a lot. It comes from you, so thank you again. My pleasure, Muhammad. Thank you very much for attending my presentation, and wish you all the best in your last year. So, okay, let me flip the cam and make the closure remark. So at the end, thank you very much all of you for attending my presentation today, and hopefully I can see you soon in person and talk with you again. Thank you very much.